should we be sending um the dull Nuffy, or like who should we be more um conscientious to possibly send it off to, or should we always be like, heme, what do you think?
That's a great question. I think that everyone should be tested and everyone should know their Duffy status. I know that I'm Duffy non-null, right? And that's just because I could test myself.
It's an extra test, right? You don't get it with like your
So that
regular
part of the
like
problem is that
type and screen.
the cost of the Duffy test is incredibly cheap. It's $10, the same as getting a type and screen. It's also functionally an easy test, as in it's not challenging for the techs in the lab to do it. It's a type and screen. However, there's a lot of systems issues. So in most places, including all places I've worked before, it's nearly impossible to get a Duffy test. At least when you type in something like Duffy, it won't call up as good order set. You have to know the backdoor way to either communicate with the blood bank or put an order in. And then also the communication between lab and clinicians is often pretty poor too, where, it's a little odd where the results get put in at places like the West Roxbury VA. The results don't get put into the chart at all unless there's a note. And so there's a lot of disconnect between orderability and interpretation, but the cost and access to reagents and ability to do the test are really simple. And so there's a lot of implementations of systems updates that we need to do to increase that access. I do think it's okay to order it in primary care if you understand what you're using it for. Let's say you have a patient in front of you that has a neutrophil count of 1,300, which turns red and you're worried about it, but you've heard the podcast, and so you're aware that the lower limit of normal for someone who has the null phenotype is 1,200. You made sure they're not having fevers. You made sure that there's no signs or symptoms of any sort of leukemia or the malignancy. You've kind of assessed all the other things like autoimmune disease and infection and new drugs. And if the person's healthy, they've had this level forever. That is a very appropriate and very encouraged time to obtain the Duffy phenotype. And if it's null, then you can have that evidence for the patient and say, hey, you are the null phenotype. This was an advantageous mutation. You are protected against malaria. This was a great thing. Our system is broken, and our system has not accounted for what your normal neutrophils are. We're working on it. Here's this, reference range that's for you. And if we use that reference range, it tells us that you're healthy, that you're normal. You don't need hematology. You don't need extra testing. You are not at risk of infection. You can go about your life. And that's the way I would use it. I worry about people going first to getting Duffy status in a neutropenia evaluation. We really do need to be careful that we're still assessing for all their signs of disease. The Duffy Null phenotype is so common. So you're going to get people who have leukemia and drug-induced neutropenia and autoimmune disease that, had neutropenia from those sources and might still have the null phenotype. So important to still do that complete assessment. But if you see a person in front of you who has an isolated neutropenia that's been stable over time with no other concerning signs or symptoms, Duffy Null, the Duffy Null associated neutrophil count is the diagnosis of exclusion and likely could be what's going on with that person. You don't need the test, but it's nice for yourself and for the patient to kind of have that evidence that your theory is actually correct.